Oh, there we go. Hello, and thank you for joining us tonight for our free webinar, Ask Me Anything About Sports Acupuncture, Panel Discussion Part 2, moderated by Whitfield Reaves and joined by our esteemed panel of Chad Bong, Hilary Patzer, and Jenny Nieters. My name is Jeff Bloom, Education Marketing Manager here at L.OM. For over 40 years, L.OM has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. To the right of the video screen, you will see 3 tabs: Chat, Questions, and Polls. To chat with other attendees or to communicate any technical difficulties, please use the Chat tab. For questions of our speakers, please put them in the Questions tab so Whit will see them. Please note that each webinar is recorded, and immediately following the conclusion, you will all receive an email with a link to view the video on demand. You may always visit our blog and use the free webinar tag to find all of our previously recorded events. From sports acupuncture to neuroscience to Chinese herbs, you'll find something interesting for every practitioner on the L.OM blog. Now for our featured speakers. Our moderator is Whitfield Reaves. He has been working in the field of sports medicine since he first began practice in 1981. He earned a Doctor of Oriental Medicine degree in 1983 that included a thesis entitled Acupuncture in the Treatment of Common Running Injuries. Whitfield's experience in sports medicine includes the 1984 Los Angeles Olympic Games, as well as numerous track and field, ski racing, and cycling events nationally over the last 30 years. He has been in the forefront of acupuncture sports medicine field, emphasizing the integration of acupuncture with orthopedics and anatomy. He is the author of the Acupuncture Handbook of Sports Injuries and Pain, and his popular acupuncture sports medicine apprenticeship program uses a small group mentorship style in the instruction of orthopedic style acupuncture. And his new upcoming live virtual events are now available to purchase at losoms.com, so check your email after the webinar for a link to see those. And then for our panelists, Chad Bong is one of the founding members of the Sports Acupuncture Alliance and founder of the Pinpoint Performance Podcast. Both focus on helping to bring together and provide educational opportunities for the orthopedic and sports acupuncture community. Chad currently practices at Philadelphia Sports Acupuncture and the University of Pennsylvania, where he tries to help his patients continue doing the sports that they love. Next is Dr. Hilary Patzer. She has a goal to support athletes in achieving their highest level of performance and athletic success. She's a doctor of Chinese medicine, licensed acupuncturist, and Chinese herbalist. Her tools of the trade also include her being a level 3 fascial stretch specialist and certified in cranial sacral therapy and neurokinetic therapy. She currently serves as a sports acupuncturist for the Minnesota Viking and treats professional, elite, college, and high school athletes from various sports. Lastly, but not least, Dr. Jennifer Nieters specializes in sports medicine, orthopedic injuries, and athletic performance. In addition to her private clinical practice, she is the team acupuncturist for the San Francisco 49ers and the St. Mary's College men's rugby team. She teaches sports acupuncture with Whitfield Reaves in a sports medicine apprenticeship program and advanced training for acupuncturists. She works with professional and Olympic athletes including MLB and NFL players. And she also served as the event acupuncturist for international rugby tournaments, including the Rugby World Cup Sevens in San Francisco, the Silicon Valley Sevens, and the Las Vegas Sevens. I am now going to get off the screen and let our panel talk.
Thank you, Jeffrey. And as we know, this is Ask Me Anything About Sports Acupuncture. So this is designed as questions. And so I just want to say a couple of quick things, and then we'll let our 3 great acupuncturists answer the questions. I'll kind of stay out of it. But I just want to make sure that we give reverence to the empirical tradition. We got to understand that for all the decades that we all have, the 4 of us here, back in the early years, there was not a book that you could open up that would go, oh, Achilles tendonitis, here's what you do. Oh, shin splints, here's what you do. All of this stuff got figured out. And it got figured out by the community of practitioners that were doing this work and communicating about that work. And so what we have evolved thus far, I think, is a beautiful, wonderful body of knowledge about orthopedic acupuncture, and it's really new. It's not, 50 years ago, none of this existed in the books. So we really need to give kudos to everybody in the community that has helped to figure something out and to communicate it and to share it and what have you. And so Hilary has a great role with NFL athletes, among other things. Chad has done great work with his Sports Alliance. Jenny works with the 49ers, communicates all the time about this medicine. She assists me, as Chad did at one time, in my teaching. And so everyone here has a perspective that I think is really, really important to listen to. And additionally, L.OMS has been awesome. L.OMS has sponsored the sports alliances that Chad has worked so hard and his staff have done. We worked with them to get some 75 millimeter needles. And they were very, L.OMS was very, very helpful in getting a number of needles and equipment and what have you. And they've given us the time to do all this. So we have a great corporate sponsor who just loves us and loves what we're doing, and so make sure you support L.OMS. They have helped, fuel a lot of all of this. So end of discussion. Let us start. And while we await a few more questions, I asked each of these colleagues of mine, what have you noticed lately in your practice? Just a real simple, brief, what have you noticed? What's happening out there? So maybe Jenny, maybe you'd like to start with that.
Yeah, so one thing that I keep hearing back from patients and athletes is just a feeling of being heard. And I feel like, sometimes I'm always studying anatomy and orthopedics and assessment and needling, but really it seems like lately what people want most is to be heard and listened to. And it was very striking. This past week, I saw an athlete that had been run around for 2 years, NFL player, and he's been to several different doctors, and he's had 5 surgeries, and they're recommending more surgeries for him. And just letting him tell his story and listening to it, I told him, I don't know if I'm going to be able to help you, but I'm going to try based on my assessment. But he said, it already helps that you listened to me. He said, you're the first person in the last 2 years who listened and cared. And so that really hit home for me. So that's something we can all offer, no matter who you are, we can offer that to people.
Wonderful. Beautiful. Yeah. Thank you, Jenny. Chad, what's cooking?
I don't know, but I definitely second that from Jenny. I mean, I had a patient this week who was like, I went to the doctor with an injury from rowing in college. We had our conversation. At the end, she said, what exercises can I do? He said, you could ride a bike and you could row. Oh. She's like, what? I got an injury from rowing and you told me I should row for my exercise? So clearly was not listening to her. So she was, needlessly to say, mad. But my thing is on the East Coast, lots of tennis, lots of pickleball is somehow became this huge sport on the East Coast. I don't know if it is other places, but enormous right now. Paddleball in the winter, and I'm just seeing a ton of elbow injuries. And I guess my little clinical pearl on elbow injuries is, yeah, we all know to do like resisted, extension, resisted flexion, all that kind of stuff. But make sure you're also checking resisted supination and pronation. And my little trick also would be to test each finger. So have them do, if they have lateral epicondylitis, have them extend each finger with resistance, and you might be able to even isolate down to more specific muscle tissue than just having them do the whole hand. So there's my little pearl for the day.
And that's precise. I
love that. Precise.
Yeah, yeah. And Hilary, what are the birds tweeting up in Minnesota?
They're getting blown away at the moment. We don't have birds. They just got blown away. I'm kind of more along the Jenny line right now. I was thinking about this and, you know, so I've been in practice 11 and a half years, which feels like a long time. Not compared to so many before us, but, or WIT. But I was really thinking about when you start to have that confidence and that knowledge of anatomy and Chinese medicine, and you're able to speak in English to them and in terminology that, you know, as Whit said, I work for the NFL, and they don't need to know about qi and yin and yang and all of that, but they just need to know like what's going on. And when you speak to any patient in that English terms and you're able to talk to them about what maybe another doctor or PT or a chiro or, you know, the orthotics that they're now in and how that could be impacting their knee and, you know, all this stuff, they're like sponges, you know, because they've been getting so many, you know, kind of like to Jenny's point, just listening to them, they've been getting so many individual responses without anybody sort of sitting back and doing the Mayo approach of like looking and hearing and, you know, connecting some dots, and that, you know, taking that extra 15 minutes to really try to understand like the journey that they've been on, and when a certain injury kicked in, and then something, you know, an intervention that they maybe had, and then another injury that was different, and then, you know, another intervention, and they're getting the runaround, to sit back and to be somebody who can hear them. You also have the anatomical, the physiological, and the acupuncture knowledge to not tell them what's going on, but to say, hey, have you thought about this? Do you think that maybe this could be tied to it? And, you know, just maybe less is more, because, you know, we live in America, or some of us do, on this, and just more, better. And sometimes just being able to help them pull back and go down to the bare bones. Or I think I use the word unplugged. Isn't that what they do on albums? Like it's somebody unplugged, is really, really valuable. So I guess Jenny and I were kind of on the same thought there. Just being able to care, especially during COVID, people really, really, really want to be heard. They're struggling.
Very good. You all have similar kind of feel here to this. Okay, we got the first question was Cinna Washington, and I don't think it's an answerable question, but Cinna says, what are the most common acute and chronic sports injuries, and how do you treat them? So if you give me about maybe 60 to 100 hours, I could answer how do you treat them, as could my other colleagues here. But I think that I've got a book that Chad and I put together called, I don't even know what it's called, The Acupuncture Handbook of Sports Injuries and Pain. This was what we felt like was the most common injuries that we are faced with. And so that list of injuries is a pretty good list, but everyone's going to have a different list. You could look at close to the bone and see what injuries are in there. You could look at Matt Callison's work. So that's a tough question, but what is an answerable question is your second part. What are your favorite sports liniments and how to use them? So let's jump in. Who wants to answer that question? Sports liniments. I'm out. I'm useless. Somebody else.
I'll go before Jenny because I think she might get more in depth than I do. I love manual therapy, so I do use manual therapy a lot. Some may call it a little bit of massage, but I think it's Twina. I love CBD. I get mine from Lhasa. They have great brands. I personally use a lot of Charlotte's Web. I also use essential oils, some of their athletic blends, and then also just the blends that I know to do really well with either muscle, bleeding, tendon, along that line. I also use the white and the fast patch from Way. And they just came out with a lotion, so that makes it easier on joints. But I think that more than a topical, it's what your needles do in your hands. Personally, I think the topical can make it feel better and can be kind of like ear seeds. It's something to take home with them. But I wouldn't, me personally, my feeling is I wouldn't hang my hat on a liniment. But some people on here would be like, you're wrong. This is really effective. This is my experience. And I think we all have our own experience with different aspects of our medicine. That's just been my experience.
I totally agree with Hilary. Get good with acupuncture. Let liniments do the secondary work. And I think Chad's saying thumbs up. Jenny.
Yes, get good at acupuncture. However, I do like liniments and I like putting my hands on people. So I do use them quite a bit. And I like Spring Winds line. They have, if you look them up, they'll tell you what stage of injury, which is kind of nice. They have some compresses and different liniments. I also like Blue Poppy's liniments, just sending people home with those. And again, they have each one that has the different stages of injury and, chronicity. And then there's something I got, actually, I think it was at the Acupuncture Sports Alliance conference that Jeffrey gave me a sample of Dr. Guo's liniment. Maybe we'll put anyway, so that liniment, I love the texture. I like the smell. And then I used to use it on rugby players with, because they're hitting hard with their shoulders, especially like people who are in the scrum and on their shoulders. And they will say, I need you to do my shoulders right before a game. And their pain will go away. So they love that, Dr. Guo's. When I went to the 49ers, I said, can I use this liniment? And here's the ingredients and here's the manufacturer. And they sent it off to the NFL. The NFL said, yeah, all those ingredients are fine, but don't use it because we don't know the manufacturer. We don't trust it. So then I was kind of frustrated because I love my liniments. And then not only that, there was another acupuncturist working there. And I said, well, and he was using Spring Wind. And I said, could I use those? And they said, oh, no. And now he's not able to use those. And he was like, Jenny, why did you ask? Now I can't use mine either. But then I did find a company that is American made that the NFL's okay with called Wintergreen Sport. And so lately I've been using their arnica oil and magnesium lotion. So yeah, but I love the Spring Wind and that Dr. Guo's liniment.
Chad, sounds like you've got something brewing now.
No, just that I've been trying to answer this question for years, and I ask everybody on the podcast, every herbalist, and my answer has always been exactly what the NFL said was, we don't know who's making this stuff. We're fine with the ingredients, but we don't know who's making this stuff. And could it be like being produced next to something else that is banned, such as ephedra or whatever, mahong? So I've always been super leery, and that's why my answer to that question is I don't use any of this stuff, because I'm not putting anything that's not like, I use organic, vegan, nothing in it massage cream for every athlete that I treat, because I'm not going to put anything on them that even could possibly get them a positive test, because I would never recover from that. And so it's good to hear that there is a company that's making some herbal stuff that's at least. So
that company, Wintergreen, they are used by the USA Olympic rugby team. And so that's how I came across them at the LA Sevens event. And so I figured if they're okay in the Olympics, then they're okay. And then I did have the NFL look at those too. But
that's not a comprehensive line like Spring Wind, which is very comprehensive with Chinese herbs. So
it's
but
better.
Still,
you only have to worry about it. You only have to worry about it on the people who are being tested. Otherwise, use the stuff that we're more trained with. But the people who are being tested, man, you got to be serious about that. That's a 4-year ban. That's the end of a lot of people's careers. So I take it seriously.
Okay, Carolyn says, I'm interested in knowing how your time is divided among professional teams, or school association, and your private practice. So both of the women could certainly right now comment on that, because you got football and private practices. Percentage. Yeah, go ahead, Jenny.
You want me to go? So right now the guys are off, and Jenny and I don't know when they'll be back. OTAs would be starting really soon, but the general consensus is that it will not be in person. So training camp will be in person, I'm guessing, and potentially open to the public this year, which will be different. But during the season, so starting the end of July when training camp starts until, hopefully the Super Bowl, so the first weekend in February, it is gangbusters. And I would say that my practice at that point in time, just because I can't make it work. So I go to the facility twice a week. And then I treat the guys like 4 to 5 days, honestly, at my practice as well, especially as they get later in the season and the practices get shorter. I would say that I treat more than half of my clients, my patients are players. And then right now, especially with COVID and everything, like I'm ramping up and sending out the energy that I want more patients to come in to, keep us all alive. But I'm also still treating the players that are in town, and MLS is kicking in, and college and high school. So right now I would say my practice in the, let's just call it the NFL off season, and hockey's still going on. I treat NHL. I would say is more like maybe I'm treating like 20 to 30% player, or like elite college level. And during the season it's over 50. So if you really like testosterone and you really like males, then this is a good profession. And I'm being completely serious too. Like I have women come in and I'm like, oh, I love my ladies. I mean, I would say the vast majority of my practice is honestly men, even my regular patients. I see a lot of men. So that's different than a lot of other practices.
Okay, and Jenny, and listen, could you all, OTAs, not everybody knows what all these things are, so maybe translate if necessary. So, but go ahead, Jenny. Let's see what you can do with this.
During the season, which starts for me probably July this year, last year started at the end of August, then I'm at the facility at Levi Stadium Tuesdays and Fridays for a Sunday game, and then that alternates if the game's on Monday or Thursday. But I try to be in my clinic on Wednesday and Thursday during the regular season. And I tell all of my patients that are normal human beings, like, I'm sorry, this is what it is. And occasionally there will be something that I have to reschedule. And so I let them know ahead of time, and then but now in the off season, I'm only at the stadium 1 day a week. And as Hilary said, there's, like in my case, there's Warriors basketball, and then there are players that are coming in to town, and then they want to be seen in the clinic. So I try to be in my office Tuesday, Wednesday, Thursday, and then down at the stadium Fridays. And then sometimes I have the wonderful experience of getting to teach in Whit's program, and that usually happens on Saturdays right now. So yeah, that's
so Jenny, would you say 50% is the football, when the season is happening, 50% are football players either there or in your office, 50% are your private clients, something like that?
Yeah, and then last season there was a new thing where I started doing athletic performance at the hotel the night before and the morning of home games. So then that was an additional 2 days that I was down there. So often a Saturday and Sunday. So yeah, no, not much of a life. And thank goodness I'm an empty nester now, and my son's at college. So my husband's very understanding and a 49er fan. So.
Good. Cool.
Yeah.
Chad, Deanna says, I have a patient with Achilles tendon that is fraying near her lower insertion after taking up tennis again at age 60. She tried prolotherapy and it did not work. How would you treat this?
Has anybody listened to my podcast recently? This is my problem. Actually, I've come to the conclusion that this is not my problem. I'm concluding that I have a nerve impingement, and I have solved it by cupping my leg, my lower leg. I have basically broken that nerve free, and I've solved the problem. I had measurable pain from the middle of my calf down to my Achilles. You could take a ruler and measure it. And from a neurologist I've talked to, that's nerve pain when you can just be like, it starts here and it ends here. So, I guess maybe I have some sort of Achilles issue to go along with it, but I don't think that was actually my problem. So how would I treat that? From an anatomical from a Chinese medicine standpoint, it's pretty clear that that's probably bladder meridian. I guess you could also say that it's kidney, and there's probably some deficiency going on if they've torn that off of there. But I would, as far as anatomy wise go, I would definitely be into their calf, into the muscles that attach into there. So needles into spots in the gastroc and the soleus for sure. Although I would also be investigating like posterior tibialis and things like that to see if there's other stuff going on that low. But you can't ignore the hip and things like that. As I think we talked about this last time we did this, right, Jenny? Where you had the patient who had an Achilles problem, and then you put some needles in his hip, and he's like, "That's the best my Achilles has felt in forever." So I don't think you can ignore the whole chain of how we move. But as far as without knowing more about this person, definitely looking at gastroc, soleus, and then threading. It gets really fussy when you're talking about where it's pulling away at the attachment there, but there's not much space to thread a needle in there. But I'm threading a needle under the skin, but not hitting the tendon, and getting as close to that spot as I can, and then running some stim across it. So as far as the local part of the treatment, the non-TCM part of the treatment, although you're still using bladder 57, bladder 58, maybe bladder 55, 56, something like that. And then getting right as close to that tissue that's injured as you can and running stim across. You also might want to pinch up the Achilles to see if there's another tender spot where they have an injury. How's that? Does that make sense?
I would just say be really careful, because that tendon can detach from the bone, and you run that risk. And so you've got to be, you definitely need somebody else helping you, on this case. But let's keep going. Deanna's got lots of questions. What's your favorite CBD salve? So that is an easy to answer question here.
Mine is Charlotte's Web.
Charlotte's Web. What is the L.AC OMS CBD salve that you like, Jenny?
I don't use CBD. After I heard Erica White talk about all the different complexities of the herb, I thought, wow, this is not a herb I know enough to do anything with. So I feel like I refer people to her when I have people who want that.
Is CBD, is Charlotte Web, is that the brand that L.AC OMS sells?
One of them, yeah.
One of them.
It was one that I asked a bunch of my mentors, and not to throw anybody out, but Dr. Amy Mall highly suggested that one, and she's just somebody I really, really respect. So if somebody's done the research for me, yay, I love it. And then I have an affinity for it and have used it. So I won't put anything on somebody that I haven't personally experienced or liked. I'm really, really specific about that. And, in just a second, Chad saying I don't just pop it on, my players. This is more for me and then my rigs.
Yeah.
But I really like the texture. It's really nice and malleable to work with. There's a little bit of stick. You don't want to like slip off of something. So, and it has good impact, and my patients like it. So I like it.
Good. Okay, and then Joel is asking, curious about treatments for gymnastic injuries, but of course they could be from any cause, to the brachialis, brachioradialis, and rotator cuff partial tears. So any of you all who would like to deal with those three muscle groups and partial tears?
I think learning the anatomy to be able to palpate and separate out the brachialis and the brachioradialis is probably pretty important. I don't know what the percentages of acupuncturists who could successfully separate those tissues out to be able to needle them are. Maybe it's great, I don't know. But I think the anatomy is important there, because if you're going after the brachialis and you're in the bicep, then you're probably not going to solve that problem. And then, making sure you're able to get on the brachioradialis as well, and understanding what they do, so you understand how how they're involved in all the other stuff, so you can figure out what they treat. Like such as the brachioradialis. Yes, it does supination and pronation, but it only does them to bring it back to neutral. It's not like a strong supinator or pronator. And then it doesn't really do anything to the wrist, even though, it seems like it does because it comes way down here, but it doesn't do any of this stuff. It's basically like a hammer curl in as far as exercises go. So I think understanding the anatomy there is important, and being able to find it. Once you can find it, just making sure with the brachialis that you're probably needling that from the lateral side, not the medial side, because there's a lot of stuff on the medial side. And then rotator cuffs, that's like bread and butter stuff there. That's if you get good at rotator cuff stuff, you can make a living as an acupuncturist just treating shoulders. So learning how to palpate and get needles safely into the supraspinatus, and then also getting needles into the other three rotator cuff muscles. Learning if you even want to try to get needles into the subscapularis, and how to go about that, I think would be very important. So nobody's puncturing any lungs here. But I don't know. That's not a very specific answer to that question.
Okay, but here, Chad. So breaking that down, we've got these muscles, and you're talking about needling these muscles. So right now, I think you're talking about needling the muscle belly of the muscle, or perhaps the muscle to tendon junction, going one way or the other, versus we've got a tendon problem versus doing something at the tendon. So maybe comment about the different technique you would do for a muscle belly versus what you would do for the tendon, if anything.
Yeah, I think they're probably together. You probably, if you have a tendon injury, you probably also have something going on with the muscle. So still going to get in the belly of the muscle. But then the tendon thing is, you got to be able to locate that tendon, separate that tendon, and slide needles on either side of it. And then typically I would run some E-stim across there. And if I know somebody's going to now ask the E-stim question, I'm going to do E-stim. So we might as well just go right into that, which is, for me.
Okay, so the E-stim question, Chad, is when do you decide to use electrical acupuncture stimulation, and when do you not use it? So there you go. There's the question.
I feel like I'm monopolizing things here. When do I use it? When do I not use it? I base that a lot on my patients at this point. I've actually used less E-stim in the last 3 months than I've used, for a long time. Been doing a little more very specific, like trigger point needling. But, it's a lot about the sensitivity level of the patient and how, if I've treated them before, how sore do they get? It's mostly about reading the patient, and do you think that they'll do well with E-stim or not? And then it's about how strong you do E-stim, which for me is really as light as I can do it with them, which I want to either see that if I'm in the belly of the muscle, I want to see that the muscle is slightly twitching, or I want them to feel it. Doesn't have to be both. I just want to know something is happening there. And then if I'm along the tendon, it's just I go until they feel it. So for me, the tendon part is just trying to get a needle on either side of the tendon, as close to the tendon as I get without hitting the tendon, because tendons tend to get angry when you bang into them, and then running some gentle stim across it. That's pretty much how I would go about that.
Cool. Thank you. Hilary, E-stim, when to use it, when not to use it? Is there something clear?
I second all of what Chad said, and I'll go a little bit deeper that can change per treatment on what the patient can handle. So there's often times where I do the treatment and then I go back and I'm charting and I go, I used Electro last time. I didn't this time because they didn't need it. I think you want to pay a lot of attention to deficiency and robustness, but I do have some patients, like I had a young college D1, football kid today, and he wants that sensation, and it's almost like a massage for him. And I keep it low. Like the scale that I talk to my patients about is like 0 to 10, 7 is pain. I want you at like a 2 to 3, and sometimes you have vesiculation with that and sometimes you don't. But I'm watching really closely because I would really rather not have vesiculation. But then oddly enough, right, wrong, or otherwise, like some of my patients really want that vesiculation. Like they mentally want that noticeable experience, and they're totally fine the next day. Where somebody else might struggle a little bit more. But I do like E-stim to bring attention to that area. Much more methodically and consistently than my hand can do with the needle. So, but sometimes I'll use it on a patient, as I said, and sometimes, the next week I won't, because it just doesn't feel right. You really want to pay attention to, is your patient coming in super aggravated? Are they really tired? Are they emotional? Like all of that matters, because that's who's presenting at that point in time for me.
Good. Jenny, what about that same question?
Well, yes, it's depending on, who's presenting in the moment, just like they said. So I would say I don't use it 100% of the time, but I use it most of the time. I do a very gentle style. A lot of times I'll use a pointer XL, like one of those pointer plus, to confirm like a location. Did I get the muscle that I wanted? And then I might hook E-stim up to 2 needles with my E-stim 2 machine at like maybe around 8 hertz and just turn it up till I just say, I just want you to let me know when you feel like a really gentle tapping sensation. It shouldn't be painful at all. If it is, I want to turn it down right away. You might feel the muscle moving, you might not, but I just want you to tell me when you feel like a tapping sensation. And that seems to be pretty well. The person who then gets aggravated after that treatment, that next treatment, I'm probably not using E-stim. But most people.
Don't use E-stim if it made them worse. Okay.
Yeah, if it makes them worse, I'm definitely going to like leave that off the next one. Yeah. So. Yeah, but that's very rare that it makes them worse.
Well, what's not quite being said, but we're talking around it, is like Hilary used the language, bringing attention to the area with E-stim, and so that would imply perhaps proprioceptive fibers, some afferent fibers, communicating back to the brain about that tissue and what's happening there. Chad was talking about threading along a tendon that's frayed with E-stim, and I think that his in that explanation, I think he's seeing that the E-stim is actually, for lack of better words, activating the chi in the blood at that injury site, which is different than the feeling of bringing attention neurologically to an area. And you can layer on a number of different questions or processes of what electric current is doing to the tissue, which could then also help you answer that question. Should I use it or should I not use it on a patient? Depending upon your explanation of what that point and what electric current is doing in that patient. Like if you're on a motor point, fasciculating a muscle is different than threading a tendon and putting current into a tendon sheath. But
yeah, so I think of that as like what you're doing locally on a cellular level, like to the local tissue, and then what's happening to the nervous system and the body's connection to the brain and the ability to find that part of the body and communicate with it. But then there was the question of like, okay, deficiency or excess. And I find like if I'm going into an SI joint to treat those ligaments in there that are in some cases, especially in women, really loosey-goosey, and there's a lot of space in that SI joint, I'm doing needles, 2 needles with e-stim into that joint space and putting current on. But someone who also has a tight, locked up SI joint that's kind of, you know, hot and inflamed and more of an excess condition, I'm also doing that same thing. And in both cases, it's resolving the issue. So for me, there's this question of, is it adaptogenic? Because this is like clearly, to my mind, a deficiency condition, and this is clearly, in my mind, an excess condition, and yet they both respond to the same treatment. And so that's a question that I have, in why does that work in both cases with the same e-stim?
I like that, adaptogenic. Huh, I like that. Yeah.
Well, we have adaptogenic herbs.
Yeah.
So.
Okay, the question that always gets asked, Erica, what is the difference with sports acupuncture and physical therapy, dry needling with sports injuries? For example, the hip flexor. Let's not worry about the hip flexor. Let's just, what is the difference with sports acupuncture and dry needling? Jenny, that's fresh on your mind. Why don't you start?
Yeah.
But I want to hear from all of you on this one.
Yeah. Okay. So to my mind, because a lot of people ask if I do dry needling, and so, and what is the difference? So I've been actually asking, like as a sense of inquiry, among my fellow acupuncturists and also among my athletes, what is the difference? Because a new guy will come up to me and say, I'd say, okay, so have you had acupuncture before? And he says, no, but I've had dry needling. I'm like, okay, well, how'd that go? Well, it hurt a lot. And they're like, okay, was it done by, you know, who did it? And usually it's not an acupuncturist. And I'm like, well, you know, what brings you here today? And so then they're going to tell me what they want. But it's interesting to me. So the difference I see is it's a technique, it's a style of acupuncture. If you are not using a hypodermic needle, then you're using an acupuncture needle. So then needling into tissue that is dense or, you know, like a trigger point and just not shaped right or inhibiting the muscle because of it's choking off chi and blood, then that's acupuncture into a trigger point. But acupuncturists don't seem to feel comfortable with that. They want to know that they are trained in dry needling, because I have talked to many sports acupuncturists and I say, do you do dry needling? And they say, well, I'm not trained in that. And I'm like, well, did you go to acupuncture school? But so yes, you are trained in that. You're trained to feel the channel palpation, feeling the muscles, feeling the tendons. Like we know this, we have this. So it's near and dear to my heart, this question, but I think what it is really, it's who can do the needling and how many hours do they have into learning how to do it, and then who gets paid for it. So, you know, who can bill insurance? I don't bill insurance. I have a cash-based practice. So that's not so much a concern for me, but I don't think there's any chance of losing our scope. But I do think that it's interesting to see. And before we started this conversation earlier, Hilary was saying, yeah, but I'm better than they are. And so like than the people who are doing dry needling. And I think that's our job. Our job is to be better, deliver a better patient experience so that people have a good outcome from their needling experience. And then they know that they would prefer to have dry needling or acupuncture done by an acupuncturist. So that's my feeling. I'm a little passionate about the topic right now.
Any other, either of you, Chad or Hilary, dry needling?
I can go since I'll then hand the baton to Chad. I think we probably all three of us, hey, Jeffrey, we should probably have just a lecture on dry needling and acupuncture, because I think it's really a topic that many of us are so passionate about. And that's one of the words that, beyond the fact that, I mean, I had the question come up today from this, college player, like, what's the difference? And I really like to take the time to educate my patients. I get it a couple times a week at least. So I have educated probably hundreds of people by now on the difference as I see it. I try to be very factual, not emotional. I don't start to breathe or hyperventilate or, start to talk really loud as they're peacefully laying on the table after a really nice but effective anatomical needling. So yes, as Jenny said, I think our job is to be better, that we let our talents and our abilities speak, because we aren't going to win legislatively at the moment. We are way outnumbered unless we all come together. I also think, and it's one of the things that made me laugh, is Jenny's like, I'm passionate about it. One of the things that I tell my patients is, it is my passion. Acupuncture is what I do. It is my career of choice. It's not that my tool didn't work and so I use somebody else's tool. It is who I am. I am Hilary. I am acupuncture. So I make it very clear, because that matters to people, that you have that much energy and belief in yourself. It's not just, well, I threw some stuff at you and it didn't work, so let's try this. And I hear that come out of patients' mouths all the time. Well, they told me like nothing else was working, so let's try this. Like, acupuncture is not just a let's try this. Like, it is a really profound and powerful medicine when used appropriately. I like to use like analogies. And so and this one might get me in trouble. I hope not, but I just say it really easy I really like to talk to my patients in English, and I just go, I wear contacts, but it doesn't make me an optometrist. So the level of education for me, because I've taken classes with Whit, I've taken classes with Matt, I have my master's, I have my doctorate, and I have 11 and a half years of experience in a clinic. I work on a lot of pro athletes. I take a lot of other continuing ed. I can say with belief that far outweighs the PTs or the trainers or the chiros that might be doing it. So for me, it comes down to, as Jenny said, those hours. But instead of giving people the number, because it is impressive, that's what I say. I put in my contacts, but I'm not an optometrist, to kind of express the difference in, I have like 5.5, 6 years of education alone, not to mention my practice, versus a weekend. And I have done a dry needling course because I was very curious what it was. So I flew out to Maryland a few years back, and it was pretty horrifying, to be honest. I couldn't walk for like 3 weeks because of the damage that they did to my calf. And they said, now go practice on as many people as you can. Here's a box of needles. And I mean, my jaw was just hitting the ground. So yes, to Jenny's point, we're very impassioned about it. I definitely am, as you can probably tell, but I try to be just very factual and give them easy to understand analogies, because that's what I would appreciate from somebody else. Chad.
Sure, my computer's fussing right when it gets sent to me. This topic is tough. From when I started practice and when I started first hearing about dry needling, I think what the idea of dry needling has grown, and what the idea of what PTs feel is within the scope of dry needling has changed, I think. When it originally started, it was just putting a needle, an acupuncture needle, into a trigger point, getting a twitch, taking the needle out. No needle retention, no electric stim, none of that stuff. I've seen personally this grow quite a bit from that to doing a lot of retention of needles, doing e-stim, doing facial acupuncture, like is dry needling. You know, doing things along, we'll call it the, you know, anatomy trains meridians, which are, you know, essentially acupuncture meridians. But so I guess it's hard to say where the difference lies at this point, other than acupuncture is a very comprehensive medical system that has a lot behind it, not only in the needling into the local tissue, but also in the neurology and all of the, you know, pathways of what you're treating when you're doing distal points as well, and how that can help people manage what you're doing when you're doing, I'll call it trigger point needling into trigger points. And I mean, we have a long history of this. I mean, these were techniques that were around for, you know, 1,000 years. But even if you just take the stuff that's happening here in the US, we have a really long history of it. And I know because Whit has, when I shared Whit's office with him, there's a autographed book from Janet Travell. And that's because Whit took a class with Janet Travell in what year, Whit?
1983.
In 1983. So our lineage, very specific, this specific lineage, you know, goes back to studying specifically with Janet Travell in 1983. So it's not that needling into trigger points is a new thing for acupuncturists in the United States. It's not even a new thing for acupuncturists in the history of acupuncture. But thinking about it and describing it in the physiology terms of trigger points and muscles and things like that, it's not like we have a short lineage of that or a short history of that. You know, we're going back to 83, and you know, when was that book published? When did she publish her first book? What?
78 was
78,
volume
so,
1. Yeah.
So we're pretty early in the volume 1. This is pre-volume 2. You know, studying specifically with Janet Travell, and that's one of the entry points into trigger point needling for acupuncturists. And then if you're talking about the East Coast, then you're talking about Mark Seam, also doing stuff with Janet Travell, and taking Janet Travell's stuff. Now, the theory or not the theory, but the needle techniques end up being very different between Mark Seam stuff and anybody who went to Tri-State and stuff, and people who studied with Whit, and then also people who studied with Matt probably too. There's a different needling technique to it and how you're getting this to happen, but we're still needling into trigger points. So that is something that's, you know, going on with dry needling. I think, you know, dry needling has just taken it and just described it in a Western pathology kind of way of, this is what's going on with the muscle, this is what we're doing. And they've taken that stuff from Janet Travell, who was not a physical therapist. She was an acupuncturist, or not an acupuncturist, she was a doctor. She was a
physician, yeah.
She was a physician. So, yeah, I think it comes down to, you know, to those topics. It's tough in Pennsylvania because it's technically not legal for a physical therapist to do dry needling in the state of Pennsylvania. But I rarely go through a week without having a patient who's been dry needled in the state of Pennsylvania. So that means it's just being ignored. And then there's all this issue with, well, the physical therapy board won't enforce it, even though the Attorney General of Pennsylvania has written a letter to the physical therapy board saying this is not within your scope of practice. And then none of the other boards, so we're actually under the medical board in Pennsylvania, the acupuncturists are, and the medical board won't go after people because they don't want to step on the toes of the physical therapy board. They think it's their issue to regulate their people, and it's just not happening. So I know a ton of physical therapists doing dry needling in the state of Pennsylvania, even though it's considered illegal in the state of Pennsylvania. So it's tough. But with all that said, I go back to, I just want to get really good at what I do. And if I'm really good at what I do, it doesn't matter what somebody else is doing because I'm really good at what I do. And my patients like what I do. And I can, you know, for some people, trigger point needling is the right thing. And that's what they want. And that's what they need. And, you know, you can go to town on those muscles And then other people, if you do that to them, they're never going to get acupuncture again because it is just traumatizing to them. So you need to be able to walk that line. And that's the beauty of acupuncture, is that's not the only way we can needle it. We can needle something in a different way that's much more mild. And electric stim might be the way that you can still get those muscles to change, even though the trigger point needling is too intense for them. You can do really light stim and you can get the same effect with same effect, or maybe a even better effect with electric stim.
Wow, very good. Okay, listen, we got a question, and I need a quick answer, so I'm going to answer it. What setting do you use for e-stim with muscle strain? I come from the point of view that I don't believe that there is any data that I will accept that helps me with whether I use millicurrent, microcurrent, high frequency, low frequency, a continuous wave, a discontinuous wave, a dense dispersed wave. I don't see any evidence that any of this is of any use. Targeting a tissue with a frequency because that's what the opiate receptors, that's targeting the opiate receptors. We're not targeting opiate receptors. If we were targeting opiate receptors, we'd put needles in, block pain, and we'd be real wealthy. That's not what's happening. We are needling tissues that are broken, that are pathologic, muscles that are too tight or too weak or too, stringy, or got stagnation or have tears or what have you. And so it kind of depends on what's happening of how we needle and all. And I'm making a simple question difficult. I use about a continuous wave of millicurrent at about 10 cycles per 10 cycles per second, anywhere from 5 to 10 hertz. So just a nice, simple, continuous sine wave. And that's what I use all the time on every patient for virtually everything. So as we, period, the end, I turn it up just to patient sensing, as Jenny was talking about, or I think it was Jenny talking about that feeling of the tapping and what have you. So I'll let the other three weave in things that might be important in them answering the question, but that question is simply answered in that way by me. So the next question, and there's other questions all mixed together here. How would you treat spondylolisthesis, herniated disc, sciatica? And how much success or effective has this been? This is Kavita's question. How would you treat these lesions, basically, of the lumbar spine? Guys, have at it.
That was the longest short answer I've ever heard, Whit. That's hard stuff to fix. I mean, it's hard stuff in every form of medicine to fix. I don't claim to fix discs. I don't, herniated discs. I'm certainly not claiming to fix a spondylolisthesis. And I don't really know any great ways that anybody else is fixing those things. But, in the office at some point, I'm very clear with them that I can't fix that. I'm very clear that I'm not going to put a needle in you, and spondylolisthesis, like your pars articularis fracture, is not just going to go away. That's there. We can see what we can do as far as managing the tissue around it and managing the muscle strength and the support system and all that, and see if that's helpful for you. And if it's helpful for you, great. We can keep going. If it's not helpful for you, I think I think I don't know what to do. I send them to somebody else. But I think it's important to be very clear. And this is probably going back to Whit teaching me that, if you're treating a whole bunch of stuff that you can't possibly fix, your practice isn't going to look very good in the end. So, you got to be clear with people that spondylolisthesis is not a thing, an injury that you're just going to fix, because it's a broken bone that probably happened decades ago and is now, basically what's happened is the bone that holds your, I don't know if everybody knows what spondylolisthesis is, so I'm going to explain it a little bit, but it's the bone that holds your spine in place, essentially. It's, the bone that comes out and becomes your spinous process. They break across that, and then it's usually L5, and L5 sits on a slope. So as that bone is sitting on the slope for years, it starts to slide forward because gravity wins every battle it ever fights. and eventually that bone gets into a place where it starts messing with nerves and things like that. And there's just not a way that you're going to slide some acupuncture needles in there and fix that. I think this is where you have a team approach of, you have PTs, you have a doctor, you have acupuncturists, and you work together as a team to try to build this a stronger human being so they can support some of this stuff. Sciatica, maybe you have a nerve impingement from a muscle, and that you can probably help if it's from a muscle and not from a disc.
Meaning the piriformis.
I think it's more complicated than that. I really have a tough time blaming all that on one muscle. I think the studies would show that it's not, the original anatomists looked at that and they were like, oh, a nerve runs right through this muscle. Like, this must be the problem, right? But I think over the history of people actually researching that, they've discovered that the people who actually have the nerve running through the muscle are not more prone to sciatica. So that kind of throws that a little bit out the window. So I think it's more complicated. I think you got to solve the whole hip, core complex in order to solve the sciatica problem. I don't think it's as simple as putting a couple needles in sciatica or in the piriformis. Jenny's shaking her head. Let Jenny roll with the rest of it.
Jenny, yeah. What do you say about this deal?
Also, I like to tell people what I'm not fixing, and I'm not fixing the disc, and I'm not fixing the broken bone there, likely. However, what I can help them with, and if it is helpful, and probably is working on the support system for muscles that are supporting that spine. So, and if I can do that, and they can work with a PT or Pilates, I really like Pilates for this kind of thing, because I think the core is a big piece because of the fascial connections to the front of the spine at the L5-S1 level from the core. I think that's a huge piece. But that, along with those lateral pelvic stabilizers and making sure that the hips are stable to take, to kind of stay even when they're walking, so that, they're not like really putting a lot of shearing on the spine. Over time, maybe that injury might be less inflamed and less damaged, and that spine might be more supported. And I tell them, your body is going to prioritize protecting your spinal cord no matter what. So, if your low back is tight because it's protecting this area, and we release that tightness and now nothing is supporting, so then maybe we need to activate the core and then work on the low back. And then maybe the low back won't get as tight again. And then they follow up with their trainer or their PT or their Pilates person, and they start really developing those muscles because we're in this battle with gravity, as Chad said. So, but I do like to have a team approach also. Yeah.
So I would add, Hilary, you're next. So I want to hear from you.
All I was going to say is, because I'm sure we want to move on to other questions, is basically I was like sending Jenny like thoughts, and she was like speaking what I was thinking. So I really believe in that core stabilization. Exactly. Like, go girl, go with it. So I just really agree with that core stability and helping the muscles that are, stabilizing and getting that, so that you take some of that pressure off of the spine potentially. Yeah. So go with it.
I think we all just sat up more straight in our chairs while we were having this conversation.
Yeah. And so all I want to point out is that some of those muscles involved in core stability, specifically the quadratus lumborum and the gluteus medius. Also, when they're over tight or when they're struggling or compensating, trying too hard to stabilize the pelvis or the lumbar spine or what have you, they themselves become generators of pain. So much of the pain of spondylolisthesis or what have you, the discs, et cetera, is being generated by the soft tissue, by these muscles. It's not all being generated by the disc, you know. It just doesn't neurologically work out that way. And so you're doing two things with that. You know, you're dealing with posture to support, to get everything in a correct place, and you're correcting these muscles that were generating and referring pain all over, and now they're doing it less. So you're treating a cause of pain as well as treating a cause of the postural dysfunction. So two things are happening with that. And all three of these practitioners here, all of them really know how to do this and know how to do this well. So this is something that you don't learn just in acupuncture school. So
I want to say something else, Whit.
Please.
All right. So I think two things. I think we want to prevent some of this stuff. And the way we can prevent some of this stuff, especially the spondylolisthesis, is that young people who are doing extreme extension exercises, so gymnasts, dancers, if they're having back pain and they're 12 years old, it's a problem. You can't tough out 12-year-old kid back pain. They probably have a stress fracture in their pars articularis. They need to be seen by a doctor. You can't keep pushing extreme extension exercises when when a young person is having back pain, because it can be fixed when it is a stress fracture, probably, if they take the time off. But once that thing fractures, it's over. There's not a fix to it. So please, if you know young gymnasts or young dancers or whoever else is doing extreme extension exercises, please, make sure that they're getting proper care, and somebody is looking to make sure they don't have a pars articularis fracture. And then the other thing is, make sure your people know how to move for the discs thing. If you're treating them for a disc problem and they're going home and doing, forward flexion all afternoon, you're never going to help this person, because they're going to just keep aggravating that disc, because they keep doing the forward flexion and they keep putting the pressure on, they keep squishing that disc so it squirts out the back and puts more pressure on that nerve. So until either you or send them to a PT or whatever, who will teach them how to move with more limited forward flexion and rotation, especially forward flexion, rotation, and lifting something, kind of help themselves. Not causing the problem is the best treatment. So that's my big thing I get into with people who are having that problem, is getting them to learn how to move properly. And if that's me teaching them, great. If that's a PT teaching them, great. After we bash the whole dry needling thing, I want to let you guys know that I am a team with a bunch of physical therapists, and I think physical therapy is great, and we need to work together. So I am all about finding great physical therapists and creating a team with them. So I don't want anybody to think I'm anti-physical therapist. I love physical therapists.
We all love physical therapists.
I think our medicine with their medicine makes a great combination. And I think we should all work towards that.
Yeah. So let me just again look at this back pain. Forget the diagnosis. We have lots of diagnoses. What we're talking about is treating the pain generators. We're talking about treating one way or the other the postural muscles for correct posture. And then Chad adds to this movement, correct movement. So that's the key thing. And no acupuncturist can do all three of those things. So you're gonna have to be part of the team. But treat the pain generators, treat the postural stabilizers, and get them moving properly. It's really simple. So there's a quick question here. Do any of you utilize acupuncture injection therapy?
Not legal in Pennsylvania.
Not legal in Minnesota.
Same, not legal here.
Yeah, and for me, I've done it, but I'm an acupuncturist. I love the needle. It's so much better for me than injection, you know, the way I work and think.
I've had it done.
What?
I've had it done when I was in Colorado a bunch of times, but I like needles.
Yeah, I think we all agree with that. Do you often, excuse me, often utilize master tongue or balanced method points?
I like this. Let's do rapid fire questions, yes or no answers.
Yeah. Well, the questions have got to be.
I really don't.
It's
not a medicine I really understand, and I truly love. You know what I understand is anatomy, and then like Jenny, I love my hands. So the master tongue just isn't going to work as well for the way I practice. Although a lot of people have great success, it's not my modality of choice.
Yeah, and I do not either. It's not something I've spent enough time studying.
Yeah,
I haven't studied that, but I do love the channels. And like the other day, I was palpating someone who had a really tight adductor longus, and it was weak on like a resistance test. And I was thinking, well, I could needle this, and then I just had one hand on it, and then I put my other hand on checking some distal points. And when I put my hand on liver 5, it was like a balloon deflated the muscle, and I was like, oh, that's so cool. Like, I just love our meridians and our distal points for doing cool stuff like that. But I tend towards the shoestring points I really like, and I learned that from Whit. And then I also will use Jing Wells, and so yeah, that's more.
So there's a question here about I studied at Tri-State. Some contact with Matt Callison. Can you explain how someone could enter into this type of training? So let's hear about what the training avenues are and how to do that.
I mean, there's a few programs, in-depth programs, obviously. Whit's program is one of them. Matt's program is one of them. There's a few others in California. I don't know how to answer this, but I mean, I think if you want, the way I always answer this is Whit's program is whittled down to the most precise thing that works. It's taught in a simple, clear way that allows you to take things and use them right away. And Matt's program is very inclusive, and it covers everything. I mean, if you just look at his book, it covers everything. Yeah, it is, a massive book and a massive resource. And I think it's about what you're looking for. Are you looking for like every bit of information, in which case you probably go see Matt's stuff? Or are you looking for somebody who's taken all of this information, distilled it down into the simplest form, in which case I think you go to Whit's program. And there are other programs. So,
and just super quick, I didn't mean to interrupt you. Like, you can take classes too. So you don't have to invest in the whole program. And that might be a good way to dabble. I mean, I started dabbling years ago once I decided that, because I was an elite endurance athlete. I guess I still am. So I wanted nothing to do with athletes. And once I sort of started to get over that and wanted a lot to do with athletes, I started taking some of the courses, but not the whole program. So that's also a way to just see if it resonates with you, if it makes sense to you, if it feels good to you, if it's something that you're going to be able to implement, or if you take it and then, we've all taken those classes where we take it, and we're like, okay, cool. And we get back to our practice and you never utilize even a single little bit of it. That's usually not just because you don't understand it or you're too lazy to learn something new, it's that it doesn't resonate with you. So then maybe find something else, I think.
Yeah, it's certainly easier to take a class here and there and learn who you like to learn from and what style you like to learn. And I think that's the way to go with it. Yeah. Jenny, you're feeling
Yeah.
you're too involved in one of these programs.
I teach in Whit's program, so there's that. And so obviously I love the work, and I like that it's a small group, and I like feeling connected to everybody and the community that gets created out of that, and connection. And I still hear from past students, and get to answer questions, and then we have. So I like that. But I took Matt's a course from Matt, which is what got started me in sports acupuncture and had me fall in love with it entirely. I'm gonna do an assessment, and then I have a needle, and then I reassess, and it's like, woo, like magic, something just changed or didn't. And then I know, like, either my assessment was wrong or my needle was wrong. So I like that all. And so, but I've also taken NKT and some stretch therapy, and I love learning and anatomy. And so I think, right now there's so many online classes, and you can just kind of dip your toe in and see, is there a teacher that resonates with you? Someone who makes you feel empowered, because there are those teachers out there where you take their class and you're like, well, that guy's a genius. And then you're like, and I will never be that good, or I never can do what they do. But then you take a class from someone and you're like, okay, Monday I have a new tool to use in my clinic. So I think, there's two things there. There's what can you implement and learn and make it your own. And then there's, what teachers resonate with you. And then you can do what I did, where I found Whit, and I basically just followed after him wherever he was teaching to keep learning and just really deep dive. And hopefully whatever it is that you find, you just follow that passion and that thread of interest and excitement. And I homeschooled my son, and that was our model, was this idea of unschooling, where you find your intrinsic motivation to learn of what's exciting to you, and you follow that thread. And so I learned how to do that for myself through homeschooling my son too. So
I've never heard you say that.
We're unschoolers. We are radical unschoolers.
Yeah.
And I think that's something really important that Jenny said. Well, a lot of really important things, but the anatomical part, if you do feel like you want to get more into this orthopedic sports medicine world for acupuncture, and you don't know the anatomy really well, spend some time doing NKT, doing some of the stretch, doing
what is NKT?
Neurokinetic therapy. It's some light muscle testing. I've also done it. I am certified in fascial stretch as a fascial stretch therapist specialist. I've learned a lot of anatomy along the way. So these programs with Whit and with Matt aren't as intimidating for me. But if you are just hot out of your master's and it wasn't one where you did a really deep dive and you just colored in your coloring book and you think you have a kind of understanding of it, maybe go in and do, anatomy trains. And because I think it'll be much more enjoyable if you understand the anatomy, so that you're not so lost when they say a muscle, and then you can't even follow the treatment protocol. You don't even know where the muscle is. That would be my suggestion. That's what I really started to add, those layers of anatomy prior to really doing the deep dive.
I think that Hilary gives a really good, clear, fair picture for the type of person who wants to integrate, wants to learn all this. And she talks about anatomy and taking different courses from different teachers, and you become the integrator of this information, so I think that's a really valid way to learn. And if along that path you find someone who you really like as a teacher, great. But you can do this without having a teacher just fine, by just making sure you cover the bases with anatomy and movement and, orthopedics. I mean, there's so many courses, as Jenny was saying, so many courses out there. online, and pretty soon again back in person. So there's a lot of ways to begin, and it's this cycle. So there's not necessarily this is where you start right here. You just get into this cycle, and you're just going to enter somewhere. And wherever you enter, it's going to quickly show you, oh, whoops, I don't know anatomy, so I better get the anatomy down. And you just enter wherever you are, whoever you are, with whatever your intention is. You just enter that cycle, that process, and you figure it out. Some people really like to have a teacher that tells them exactly what to do. You do this, 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 and this, but that doesn't really exist so much, in this profession. So you're going to have to figure it out for yourself. And you're going to have to make important adult decisions about how to do this. So how about this simple question? How do you prevent the patient from returning to play too soon and making the injury worse? A problem we all see.
That's a good question. I can go first. I was experiencing it just today, which probably all of us were. Really high-end elite runner, and injuries keep moving around a little bit. And his PT is telling him one thing. He goes and he works with a massage therapist, and then he saw me, and he was, I think I alluded to it today, like you go in and you really start to bring pieces together for the person. I'm blessed with my athletic backgrounds. For me, I skied on the U.S. cross-country ski team. I competed at Ironman World Championships, and I've run the Boston Marathon a few times. So that it makes it an easier conversation for me. And I'd love to hear if somebody doesn't use this avenue or this angle. But I just sort of say, hey, do you want to be, for this situation, let's just talk about a runner who he is, doing Boston and all of this year, has a half marathon in a couple months. Do you want to be running in 10 years or do you want to run tomorrow? And he goes, well, I want to be running in 10 years. And I'm like, okay, cool. Let's find something else that doesn't cause the issue. So does your Peloton? What about, you could really work on some core. Runners are notorious for not doing strength. Let's talk about a good strength training. You will be faster if you do cross training, right? So if you understand the sport that they're in, or if you understand the physiology of it, you can really kind of talk them off of that cliff. And buy yourself some time, not just being like, please don't do that. So sit on the couch, be like, here are some other options. And do you want to run the marathon or do you want to run the 400 repeats? And usually they'll say, I want to run the marathon. And I'm like, cool, let's just give me 3 weeks. Let's see if we can start to make some difference. And then I talk about how do you start running again? And again, I'm talking about running, where the trainers for both Jenny and I mean, I can say so much to the players, but really the training staff is going to handle that. At least on my team, it's been made pretty clear. But I say, okay, now you're like a 300-pound person coming off the couch. You don't go run the way you used to. You run, walk. You see how it feels. You don't go out for a 10-mile run after 2 weeks off. Now you're at baseline 0. And so trying to help them understand that. And usually people look at me and they go, okay, yeah, that makes sense. And it sort of takes some of the panic away from them. If you give them a plan of, this is what I'd like to see. This is how I will reintroduce you, into running again. If you don't have access to weightless running or a pool, anything like that, if you don't have the technology, then we do walk runs, that kind of thing, I think is really, really helpful. If they can see that you thought through it, you're compassionate and empathetic to their experience, and you have a plan of attack for them. My experience is they absolutely will stop. I mean, I had ultra marathoner. He was a coach and he was injured and he started to see me. And I said, your race is in like a month. I said, you're ready to run the race right now. Take some time off. Let's talk through this. He was able to, which I was surprised because, you know, endurance runners can be really kind of persnickety and they really need that rush. And he went and he completed the race that he had never completed before because he had been injured, and he PR'd. And so now he sends a whole bunch of people to me. So I think when they know that you care, going back to what Jenny and I and Chad were talking about before, when they know that you truly care, they're going to listen to you because they know that you've listened to them. You're not just saying, okay, sure, you're injured. This is what my prescription says. This is me, Hilary, who just listened to you talk or vent for like a half an hour, and this is our plan. They're going to hear that a lot better than just like, okay, this is what the prescription says. That's my experience.
So I'd like to point out the process that Hilary's talking about. We've all talked about listening. That's what everybody, all three of these colleagues here all talked about listening at the beginning. Now, if you're an acupuncturist, you listen. That's one of the things we do. We smell, we touch, we listen, right? Listening is really important. But if we are a sports acupuncturist, we're listening for things like training and how they're entering into their event, you know? And so the difference here between a sports acupuncturist and say an orthopedic acupuncturist or just an acupuncturist general, the sports acupuncturist has to know training. So again, we get back to this movement thing that Chad was talking about in treating the back of, you know, you've got to work on movement. Well, we need to understand how these athletes move, or in this case, how they train and how they compete in whatever their event is. And we got to know that. And so as the acupuncturist, there's a lot to learn here. And of course you can't learn it all, but you might certainly develop a relationship with the team trainer or coach, you know, so you can start talking to them about all this. You need to know about training. And Hilary, just great job of presenting that understanding of training and working with the patient in terms of their training. So either of you, anything else?
Yeah, I mean, it really, for me, it also just goes back to like trying to convince them you're trading like short-term performance for long-term being able to do what you want to do. So if you're willing to sacrifice the next year or whatever, 6 months, whatever it ends up being, or maybe having to stop running or whatever, if you're willing to sacrifice for this one event or this one thing that you're trying to train for, then that's your choice. But you know, if you're injured and we want to get you back healthy as possible, as fast as possible, you're going to get there a lot faster if you back off and you know, limit the things you're doing and you're not doing the things that are aggravating. You're going to get back out there doing full go what you want to do a lot faster than you would if you kept aggravating it the whole time. I've treated people through seasons where just like, hey, you got to play, like this is how you make your living. We got to keep treating you. So, you know, and you got to keep playing. So we'll keep doing stuff for you. But you got to recognize that you're spending money, you know, future money essentially on this problem. So I think my computer is about to die, just so you guys know.
I just saw something happening.
I think I'm running low.
I know we're going to get stopped here, but let me just try this. This is an unanswerable question, as most of them have been. Which points have you found to be most useful for optimizing athletic performance?
Whichever point. Oh, I'm sorry.
Which points have you found to be most useful for optimizing athletic performance? I mean, obviously, nobody can answer that question, but we certainly have some ideas. Jenny, you mentioned doing pre-performance work with your football team. Maybe you can
Yeah.
start.
So for those types of athletes, it also kind of depends on their position, but in general, points that I use for the core, which I'll type in the chat box, but I did cover them last time, I believe. Stomach 21, 23, 27, and then liver 13, gallbladder 26. And then lately I've been adding on stomach 31 and Jian Qua, the extraordinary point for the gluteus medius. And then also just quick on the tib anterior peroneus longus. So in the area of stomach 36, just below the fibular head, kind of close to gallbladder 34, and then also in the area of spleen 6 for the tibialis posterior. And those are the points that I have the most requests. Could you please do those? Those freed up my ankles, those freed up my hips, those made me just feel like everything was connected. And so those are the most requested combos, at least for the NFL athletes that I'm working with.
Cool.
But
Jenny, write that down.
I will type it all down.
Yeah.
Yeah.
They're gonna,
Okay.
people are
I will
going to
do
want
that.
that. Well, one year, Chad, you went to the Olympic trials to do pre-performance. You want to chat about that?
Sure. First of all, what I do, the way I think about it at this point is my biggest job is to keep people healthy, keep them out there training, keep them out there doing their thing. That's what I do. That's what I'm focused on. That's, so my answer to that question is keep them training, keep them healthy. That's the best thing I think I can do for them, because training is really where you're going to get the most benefit. So keep them on the practice field. But yeah, so went to the 2012 Olympic trials, and basically in the morning before the trials, the morning before the race, did Jian Qua on a patient that Whit and I had both treated, and we knew, I think we kind of discovered he had some glute medius issues. He kind of was running, his feet would cross each other when he was running essentially, and we needled Jian Qua on him, and he went out. I think Whit needled Jian Qua on him. He went out for a run right after, and after that run, he called Whit and was like, "That's the best run I've had in, I don't know, a super long time or ever had," or something like that, because suddenly his glute mediuses were firing, which is pretty important for a marathon runner. And so that proved to be a very valuable tool for him. And yeah, so I went to the Olympic trials basically to do that. And then we also did one of Whit's ear protocols, which I don't know there's any way that I remember exactly which one that was, but at that point, but Whit can probably talk a little more about ear needles and performance than I can. But it was a great experience. It was a lot of fun. I had backstage passes to the Olympic trials. It was a lot of fun. You got to meet everybody there and, hang out, had breakfast with, a lot of the athletes, had dinner with them after the race. It was great.
Cool and for the record, Jian Qua is posterior to gallbladder 29 into the belly of the gluteus medius. So you can find this in some of our writings elsewhere, but that's a start anyway. Maybe Jenny, you could write the location. Yeah.
Doing it right now.
Yeah. And Hilary, what do you say to this complicated question?
I say look at their constitution and treat them. This is one of those things that I think you get to treat them more like a normal person versus just like the, amazing anatomy that they are. So if they're deficient or if they have a little bit of stagnation or excess, I think when you go in and constitutionally free them and nourish and tickle the areas that they need, they're going to perform better. That's so I love Jenny's protocol here, and Chad saying that. But if you just don't even know, but you can see, like you can feel whatever, you're super stagnant here, you're really deficient, like let me see your tongue and your pulse. I think that's going to be their greatest, performance enhancement, is helping them with what their body is not providing them. And we have that ability when we take, we can meld those two. So you heard me say constitutional, because that's how I chart it a lot. I'll just be like in some constitutional parentheses and what they are that time. So different than the anatomical ones.
The last time I dug into the research that was done on this topic, essentially, the answer was the people who get regular acupuncture perform better.
Nice.
Not that, some magic trick you're going to do right before they get, they do a treatment. I think Whit would say that he has enough empirical evidence of that, and Jenny may too, that can happen done correctly. But the answer in the research that I've read, it's been a while, so don't quote me on it that it's the most recent stuff, but it's been a while. But the answer was essentially those who get regular acupuncture treatments out, that's the thing that boosts the performance. So I'm saying with Hilary, it's helpful to treat them for what their problems are and help them get better and healthier and all of that stuff. And that's going to help them boost their performance, make them a better, super healthy, super fit, super, non-broken athlete, and they'll perform well.
I mean, that's the essence of the medicine that we've all been attracted to, is that we treat the individual, not the disease, So that's beautiful. I like that.
I'm at 9%, everybody.
Okay. One more question, and then we're supposed to have been gone a long time ago. So I'm going to do one. This is the last one that just came in. Do you find value in pecking a trigger point lightly and repeatedly when it won't fasciculate, and then gua sha to help fasciculate happen later? Is this approach you use or recommend? That's a pretty specific question. Let's change the question a little bit to, can you describe your needle technique when you're needling into a trigger point, which we're going to define as a stagnation of chi and blood in a band of in the belly of the muscle? Can you all describe what kind of technique you use, and if this would work or what have you? Anybody?
Can you read the question just one more time?
Do you find value in pecking a trigger point lightly and repeatedly when it won't fasciculate, and then use gua sha to help fasciculation happen later? Is this approach you use or recommend?
No.
No. So
if it doesn't fasciculate, you're probably not in the trigger point.
That's how I would answer that question.
Yeah.
Find another spot.
I jumped on Jenny's toes, but
no. So I don't do that, because I figure for every millimeter that I'm going through of tissue, I'm trying to get to whatever I'm thinking is the pathogenic area. But to get there, I'm heading through lots of healthy cells. And so if players need to be ready to perform, I'm going to try and create the least aggravation possible. So, it's how much time do I have with this person? When do they need to be back in the game? So, but maybe I'm going to just really take my time more with palpation and find that ropey band or trigger point in that area. And then once I find it, I'm going to kind of pin that spot with my other fingers. And then I'm going to just try and get my needle right to the depth and the spot with the most exact precision that I can. And I'm not going to jam it in and out. I'm just going to get it right to the spot. And then I'm going to let my e-stim do the work for me of relaxing that whole area. So that's how I do it.
I think that's beautiful, and I agree. Especially,
I think there's a lot of.
Go ahead, Hilary. Go ahead.
Especially pre-game or pre-something where you really don't want to hammer away. I do some fasciculation, but like I said, if you have to gua sha an area because you're not getting a fasciculation, you're potentially not in the right area, or it doesn't need that. So maybe your diagnosis is off or your understanding of it is off, because not everything that feels tight, you know, you can have lock long, lock short. There's so many different things. It might not need to be vesiculated. So that shouldn't be your only like, oh, there's my gold star, I got a vesiculation. I love how Jenny described, like you hold it, you pin it, you put it in. We all know our attention is really, really important. Your fingertips are your greatest asset. Like feel it, take your time. But if it doesn't vesiculate, it doesn't need to be vesiculated or, you know, stop, because you're going to end up, you know, like Jenny said, going through a lot of different stuff. But we learned, like, what is it? The 3 valleys. And so we learned all of those techniques. But if what you want isn't happening, try something different, or step away and have a little thought, you know, have a little, ask somebody else. Like we are all on these forums too. Maybe somebody else has a better idea.
If we're just talking about technique, it's a lot about just focus on precision, getting right into the right spot, slide that, you know, needle into the spot, know how deep the tissue is that you're trying to get to, understand that, and then feeling everything that you go through. You're not just cramming a needle in there till you get to the spot that you're trying to go to. You're feeling like, oh, that's the skin, that's the subcutaneous fat, that's the first fascial layer, that's the first muscle, that's the coming out the, you know, like that's going out the other side of that muscle, that's into the second muscle, whatever depth you're trying to get to. But when you get to the fascial layer of that muscle, it might twitch just from the fascial layer. So you don't even need to bang around in the muscle. You can just tap that fascial layer sometimes and get a twitch. I mean, Whit does this all the time with the infraspinatus, you know, when we're demonstrating, you know, how to do this stuff. But, you know, the fact, like, think about, you don't have to just bash into the needle into the muscle. You can tap on that fascial layer a little bit, or just get to that fascial layer and it'll go if you're in the right spot. And then if that doesn't work, then you can try a little bit inside the muscle. But, you know, there is a limit to how much, you know, searching around and tapping and digging you should be doing, for sure. And it also depends on when is their next workout, when's their next performance, when, you know, whatever it is that they have to do. You have to be aware of this stuff when you're treating athletes. All right, that's it. I'm off my soapbox. And
hey, Chad, if you lose power, thank you so much for joining us. And Jeffrey,
I have 8%. If Jeffrey just talks fast, I'll be
okay. So Jeffrey, it's all yours, baby. It's all yours.
I cannot thank you guys enough. That was amazing. You know, just this was our second time of doing this. It went so well the first time. We had to have you guys come back. If you guys are willing, we would have you back for a third time, fourth, fifth, sixth. I mean, we could just go on tour. It would be, you know, so much fun. So I just want to let everybody know, please check your emails after the webinar is concluded. There is a promo code to save on Whit's upcoming live events that are happening through Net of Knowledge. So check the email, there are links there. Also, he has some recorded content up there, which is amazing. If you haven't purchased it yet, please check it out. Also on sale using this promo code. We have our top sports therapy products on sale currently, ending tomorrow. So check your email for a link for that. And next up on Tuesday next week, we're doing a double feature. So at 8 p.m. Eastern time, we'll be hosting Dr. Jeremy Steiner for another webinar. And then at 10 p.m. Eastern time, we're going to host the leadership team from CSOMA to talk about advocacy. I hope to see all of you guys there. And I just want to thank our panel. I want to thank Whit. This was incredible. And if anyone has anything they want to say before we go, please feel free.
Thank you all for listening to us. I think we all have a lot of fun. I mean, Jenny, Chad, and I, and Whit, and Jeff all know each other, so it's fun to come together. And but I do appreciate y'all signing on and listening to what we have to say, and hopefully some of it will help you along your journey, because we're all in this together. You know, if you're better, then we're all better. So just keep being better. Like Jenny and I say, just be better.
Yeah, beautiful.
We might as well. Thank you.
Well, thank you, everybody. Have a great night, and we'll see you next time.
Okay. Good evening. Good evening.